Good morning, all. My topic for today's session is non-epileptiform waveforms and patterns in EEG. Myself, Dr. Divya Davison, and a moderator for the session is Dr. Ashalatha. Madam. So, coming to introduction, these are EEG patterns which are epileptiform in appearance but are not epileptogenic. And there are several studies conducted on this, and which what they have found that there is no established association with clinical seizures. So misinterpretation of these patterns or waveforms results in misdiagnosis, unnecessary evaluation, and over treatment of the patient. So mainly we have 6 named variants, which are BSS, that is benign sporadic sleep spikes, 14 and 6 Hz waves, 6 Hz phantom waves, which include WAM and fold, Wicket's RMTD, that is rhythmic mid-temporal theta of drowsiness, and SREDA, that is subclinical rhythmic EEG discharges of adult. So this is a study conducted in our own institute. They have retrospectively studied serial EEG reports of 5,200 subjects who underwent EEG through our EEG laboratory services between January 2001 and December 2009 and scrutinized, and their clinical profile and follow-up data was obtained. Mainly, they looked into the subclinical rhythmic electrographic discharge of adults in EEG, and what they have found that among benign variants, most common is being BSS, amounting to 5.1% of total EEGs, total benign variants, and SREDA being the least common of 0.07% were found in among the benign variants. So various terminologies evolved over time. The first, initially it was described by Zivin and Marson in 1968. They described it as epileptiform activity in the EEG of non-epileptic subjects. Later in 1985, Klaas and Westmoreland, they describe it as non-epileptogenic epileptiform EEG activity. And the latest terminology, that is benign epileptiform variant, is coined by Drury and Baden in 1993 and Westmoreland in 1996. So we have several characteristics for this waveforms, which differentiates it from the ictal pattern. So it is mostly seen during light sleep and drowsiness and disappear in deep sleep and wakefulness. And it may have positive or negative polarity, and after coming slow waves are often absent. And it is best identified in referential montage and may be missed in bipolar montage. It can occur singly or as a rhythmic burst. So these characteristics differentiate it from the normal ictal pattern. So first we'll discuss about the BSS, that is the most common benign variant, benign sporadic sleep spikes. It is first described by Gibbs in 1954. It is also called benign epileptiform transients of sleep, BETS, or small sharp spikes. It can be monophasic or diphasic, and waves are low amplitude with short duration, which has got wider field, and it do not disturb the background and usually not followed by a prominent slow wave. But sometimes it is associated with an aftercoming slow wave, but amplitude will be smaller compared to the spike. And it is sporadic and do not appear in runs, and it is best seen during drowsiness and light sleep, and it disappear in deep sleep and wakefulness, and it is mainly seen in adults and never seen in children younger than 10 years of age. So this is a longitudinal bipolar montage with the sensitivity of 10 microvolt, showing low amplitude, spiky waves with short duration expressed in wider field. There is no aftercoming slow waves and does not disrupt the background. And it can repeat the same patient but not in burst. This is the same EEG in common average mode. We can see spiky waveform, spiky discharges expressed over the wider field without any aftercoming slow wave, and which does not disrupt the background. So one of the DD for this is EKG artifact. So we can see this is also small spiky biphasic waves, which repeats, and it is time locked with the EKG. So that is the main difference between EKG artifact and BSS. And patient can be in awake state also. So it is time locked with the EKG. So this is also small spiky discharges. The second one is Wicket waves, which is described by William Reher and Liebel in 1977. These are medium to high voltage, theta to alpha range, monophasic wave burst. And it is mainly expressed over anterior and middle temporal leads with a negative polarity. It occurs as single fragments or a Wicket rhythms. And usually auditory stimulation or arousal can attenuate these Wicket patterns. It has got a left lateralizing tendency. So it is usually misinterpreted as temporal spikes. And commonly it is observed in adults aged more than 30 years. And there is also associated phase reversal can occur. So this is also can be mistaken for a temporal sharp waves. So this Wicket waves is usually misinterpreted as temporal IEDs, mainly because it's unilateral distribution, temporal location, and phase reversal. So this is a bipolar montage, EEG with the sensitivity of 7 microvolt, showing burst of archiform waves, which is seen in the temporal chain with phase reversal in the anterior temporal leads. Very well. Yes. The last. This one. See, I have the small burst. What we have shown is a very formed one, but come 3 seconds later. Yes, ma'am. Point. Okay. So this is also a burst of archiform waves, which is seen in temporal chain with the phase reversal. This is common average, the same EEG, which showing archiform wave patterns. So one of the common DD for this is temporal spike, which is, we can see here, spike and wave discharge in mainly in the right anterior and mid-temporal region, which disrupts the background, and phase reversal in F8, and it is clearly epileptiform. The same thing we can see in common average, showing maximum amplitude in F8. So it clearly disrupts the background, and there is a aftercoming slow wave also. So this is clearly epileptiform. Next variant is 14 and 6 Hz positive burst. So it is described by Gibbs in 1951, and synonymous term is stenoids, which is introduced by Lamboso in 1966. It is comb-like in appearance, and it occurs at either 14 Hz or 6 Hz or a mixture of both frequencies in same patient. It is predominant over the posterior temporal and parietal region, and it has got a prominent positive spiky component followed by a negative smooth rounded waveform. And it is the first variant appears in the ontogeny. It resembles sleep spindles with sharp positive phase. So in this image, we can see burst of archiform positive spike followed by a small round negative wave, which is expressed mainly over the posterior head region. So we can clearly see patient is in drowsy state. So in this EEG, we can see same morphology of discharges with 6 hertz frequency. So same patient can have 14 hertz, 6 hertz, and the mixture of both frequencies. But still it is called as 14 and 6 hertz positive burst. So same patient can have 14 hertz and 6 hertz frequency of same morphology, archiform discharges, but it's still called it as 14 and 6 hertz waveforms. Next variant is 6 hertz spike and wave. This is also called phantom wave. It is described by Gibbs in 1952. It is very brief and small in amplitude spike with a frequency of 6 hertz frequency. So spike is often very small. So that is called it is phantom wave. And it is bilaterally synchronous and maximally expressed over the midline. And duration is usually 1 to 2 seconds. It is mainly seen in adolescents and young adults. So there is a subtypes, two types subtypes, which is old classification, that is WAM and fold. WAM is seen in male patients, which is in an awake state with high amplitude spike, mainly expressed over the anteriorly, that is in the frontal region. Fold is seen in females in drowsy state, which has got low amplitude spike and mainly expressed over the occipital leads. So in this, this is a bipolar montage with my sensitivity of 10 microvolt, showing very small. In the second channel, we can see very small spike initially, followed by a wave. So this spike is very small. That is why it is called phantom wave. And it is expressed over the frontal leads and also in the occipital leads. So in the second channel, we can see very small spike followed by a wave. This is a common average. And this we can see initially it is there is a small spike followed by a round wave. So this spike is very small. That is why it is called phantom wave. So the previous one is fold, and this one is WAM. It is this is a 15-year-old male. We can see burst of 6 waveforms, predominantly expressed over the frontal region, which is monomorphic with abrupt onset and offset. So this is, we can clearly see patient is in awake state with the eye movement artifacts and myogenic artifact. So these are burst of 6 hertz waveforms, predominantly expressed over the frontal region. And there is no spiky component here.
Small spike is
Yes.
Focus on that.
We can see in the initial part, there is a small spike, which is followed by a wave. So this spike is very small. That is why it is called phantom wave. So initial part, we can see a small spike. This is a common average showing initial small spike, which is followed by a wave. The spike is usually missed. That is why it is called phantom wave. So this is one of the DD for this WAM. We can see clearly, this is a, we can see generalized spike and wave discharges. We can see prominent spike followed by a wave, which is frontally dominant with the 3 hertz frequency, generalized discharges, burst of generalized discharges. In this, we can see prominent wave followed by, prominent spike followed by the wave. So that is the difference between 6 hertz phantom wave and this generalized spike and wave. In this, we can clearly see a prominent spike. This is a prominent spike. So next variant is, we have already discussed 4 variants, that is BSS, Wickets, 14 and 6 Hertz, and phantom waves. These are all misdiagnosed as IEDs. So next 2 variants, that is RMTD and SREDA, that is misdiagnosed mainly as ictal rhythms. So this rhythmic mid-temporal theta of drowsiness, that is RMTD, is also called psychomotor variant pattern, described by Gibbs in 1952. This is because mainly it is initially thought as temporal ictal rhythm, because the temporal seizures also called psychomotor seizures. So initially it is thought as temporal ictal rhythm. That is why it is called psychomotor variant pattern. This notched, smooth or spiky morphology, 4 to 7 Hertz theta frequency. And it is repetitive and monomorphic waveform. It can be unilateral or bilateral, short burst or prolonged runs. And there is no evolution over time in frequency, morphology, or location that differentiate it from a temporal ictal rhythm. And it has got no dynamicity, abrupt onset and offset, and seen in drowsiness. Duration of a single run is usually 5 to 10 seconds and may reach up to 1 minute or more. So even though it is repetitive monomorphic waveforms, there is no evolution over time in frequency, morphology, or location. And there is abrupt onset and offset, and there is no dynamicity. So this is a bipolar montage with a sensitivity of 10 microvolt, showing rhythmic monomorphic theta rhythm expressed mainly over the left temporal chain with abrupt onset and offset without any evolution. It's the same EEG pattern in the common average. You can see archiform, rhythmic monomorphic delta activity waveforms without any evolution with abrupt onset and offset, mainly expressed over the left.
The dependent form.
Yes.
Or not.
Yes.
Maybe one of them. On a count like wheel, as if you're punched into the wheel. So it's a dip in the slowly. Was the middle you can see that. Yeah.
Yes. So there is a notching. There is a round wave on the downslope. We can see a notching. So one of the DD for this RMTD is SREDA, which is epileptiform, which is delta in frequency and predominantly expressed over the anterior temporal region, which is typically unilateral and seen in both awake and sleep state, and there is a clear evolution in amplitude and frequency. So SREDA is epileptiform, while RMTD is a benign variant. So in this, we can see a sinusoidal sawtooth waveforms with a frequency of 1 to 4 Hertz that last for that continues in the this EEG. This is and with low amplitude. It is mainly seen over the anterior temporal region. And same pattern continues. So sinusoidal or sawtooth waveforms with a frequency of 1 to 4 Hertz. This is SREDA, which is epileptiform. Another DD for this is temporal ictal rhythm. So in this we can see polymorphic theta to delta spike and wave discharges in the bilateral temporal regions, which ends as slow delta frequency. And we can see there is a dynamicity, there is a slow of, it ends as slow waves, and there is a clear evolution in frequency. So this is ictal rhythm. So this differentiates from the RMTD. So in RMTD, there is no evolution in frequency, amplitude, but in ictal rhythms, there will be a definite evolution in frequency and amplitude. So next variant is SREDA, that is subclinical rhythmic EEG discharges of adult. It is first described by Barbara Westmoreland and class in 1981, and it is the rarest benign epileptiform variant. So it is first described by Westmoreland and class in 1981. They described it as unusual transient EEG pattern consisting of repetitive bilateral sharp contour waves in the range of theta to delta frequency lasting few seconds to minutes, which disturbed mainly over distributed mainly over the posterior head region, parietal and temporal region, without subsequent evolution in frequency, distribution, or morphology. So it is seen in both awake state and drowsy state, and usually seen in adults aged more than 50 years, but also reported in children. There is another term called atypical SREDA. In atypical SREDA, there is some characteristics. The frequency is in delta rhythm, and there is a focal distribution, and it is a notched rhythm. But there is no clinical significance identified till now for atypical SREDA. So this is common average. This is a longitudinal bipolar montage showing 70-year-old, 52-year-old male with in normal awake state. And the second EEG, we can see abrupt onset, monomorphic, theta to delta waveforms, which is expressed mainly over the posterior head region and predominantly in the right side. So these are SREDA. So we can clearly see there is an abrupt onset and it is monomorphic, theta to delta frequency, and expressed mainly over the posterior head region and predominantly over the right hemisphere. In second EEG, it continues, the monomorphic pattern continues. And when patient became alert, it suddenly stops. It abruptly stops when it became alert. So this is SREDA. So till now we have discussed 6 named variants. Other than this, we have other non-epileptiform waveforms also, which include lambda waves, mu rhythm, triphasic waves, post, zeta waves, and electroretinogram artifact. First, we'll discuss about lambda waves. These are positive waves located in occipital region bilaterally, which is in triangular in shape, which is similar to Greek letter lambda. And amplitude varies, but generally less than 50 microvolt, and duration is usually 200 to 300 millisecond. It decreases or disappears during eye closed state or eyes covered or lighting decreases. And it's seen in wakefulness. It closely resembles post. We'll discuss about post in coming slides. That is why posts are also called lambdoid waves. It is more frequent in children between 3 to 12 years. So we can clearly see patient is in awake state. We can see sharp triangular shaped waves which expressed over the occipital region, which is attenuated by eye closure. We can see there is a even appearance of alpha rhythm on eye closure state. So this is lambda waves. So it is seen when patient when eyes are open and it is attenuated by eye closure. Same waveforms we can see in right side also. So it is bilaterally represented. Associated EKG artifacts also.
What I'm asking is, can have a confusion with the EEG artifacts? Is it the value of the EEG?
No.
So,
Yes, ma'am. Yes, ma'am. So one of the DD for this is EKG artifact, but we can clearly see it is not time logged with the EKG. And it is bilaterally represented. We can see both in right and left occipital regions. This is mainly in the awake state.
Because their eyes are open, when their eye contact is scanning, that's why the eye closes.
So this is retino-occipital potential when patient is scanning the surroundings. So that's why it is attenuated during eye closure state or when eye is covered or lighting decreases. So next one is mu rhythm. It is negative arch-shaped rhythm. It is also called central alphoid rhythm because it's same frequency and it is expressed over the mainly in the C3, C4 central regions. And it is seen in awake state. It is very often asymmetrical and unilateral. And it is suppressed by individual when individual executes or observes goal-directed action. This is because it is generated from the thumb region in the sensory motor cortex. So we usually ask the patient to wiggle his thumb, which suppresses this rhythm. So this is also a non-invasive assessment of mirror neuron activity in humans, seen in children with autism spectrum disorder, and it is overexpressed in breech rhythm. So in this is bipolar montage EEG showing with a sensitivity of 15 microvolt showing alpha frequency rhythm in the mainly in the Pareto central region P3 C3 and we can see on wiggling of his right thumb this disappears and is mainly expressed over the left centroparietal region and on wiggling this mu rhythm attenuates, which disappears. Next EEG we can see when wiggling stops, it reappears and again it disappears on wiggling. So this is a central alphoid rhythm and it is mainly due to motor idling and it is disappeared by either goal-directed action or observation. So there are differences between mu rhythm and an alpha rhythm. Mu rhythm is mainly expressed over the central region, while alpha rhythm is mainly expressed over the posterior head region. And mu rhythm is seen in relaxed wakefulness with the motor idling, and alpha rhythm is mainly seen in relaxed wakefulness with eyes closed state. So it is attenuated by movement or observing the action. Alpha rhythm is attenuated by eye opening, and both are in alpha frequency, that is 8 to 13 hertz. Next one is post, that is positive occipital sharp transient of sleep. It is surface positive sharp waves, mainly seen in the occipital region during stage 1 or 2 of the sleep. It can occur in single or runs in runs of 5 to 6 hertz. It is often bilaterally synchronous, but can be asymmetrical. So this is a common average. This is a bipolar montage with a sensitivity of 7 microvolt. We can see run of post in the mainly expressed over the posterior head region. The same thing in common average. We can see an initial negative phase followed by a positive phase and repeats it coming repeatedly. And it is expressed bilaterally in the posterior head, mainly in the occipital region. So we can clearly see the patient is in a drowsy state. So these are post. Next one is triphasic waves. This EEG pattern first described by Foley in 1950. The term coined by Bickford and Butt in 1955. It has got mainly 3 phases with a total duration of 300 to 600 milliseconds. So first phase is a negative phase followed by a second wave, which is the prominent one. This is a positive, second wave is a positive wave with a maximum amplitude of 70 microvolt. And third is a slow negative deflection. repeats periodically at a rate of 0.5 hertz to 2 hertz, that is short interval. And it is synchronous, mainly in bifrontal and central, with a central predominance. So it has got a fronto-occipital time lag. This is because the periodic discharges are mainly from the thalamus, which mainly projects into the frontal region. So it is mainly expressed over the frontal region, and there is a fronto-occipital time lag or antero-posterior time lag. This is because of the differential expression over the frontal region from the thalamus. And it is seen in metabolic, toxic, and or other encephalopathies. So this is a bipolar montage with a sensitivity of 7 microvolt, showing an initial negative wave followed by a prominent positive wave, which has got maximum amplitude, and the third phase is a slow negative round waveform. So it repeats periodically, and we can clearly see there is a antero-posterior time lag. It is mainly in the frontal and frontopolar leads, and it is less expressed over the occipital region. This is antero-posterior time lag, antero-posterior lag. It repeats periodically in short intervals. So same EEG in common average, showing periodic triphasic discharges in short intervals with an initial negative wave followed by a prominent positive wave, followed by a third phase, that is slow negative wave, and with the antero-posterior lag. Next one is zeta waves. These are sawtoothed or Z-shaped delta frequency waves of duration 1 to 3 seconds, which is frontally predominant, intermittent, and rhythmic. And it represents underlying focal structure lesion, mainly acute lesion. And it is seen in wakefulness. Still, it is considered as non-epileptiform. So in this, this is by common average with a sensitivity of 7 microvolt, showing Z-shaped discharges, waveforms, which is mainly expressed over the frontal region. And we can clearly see patient is in awake state. So these are zeta waves. This is named because of its shape, like Z-like shape, which is mainly expressed over the frontal region. And there are mimickers for the zeta waves. One is glossokinetic artifact, and other is SREDA. So this glossokinetic artifact, which is a non-epileptiform waveform, and it has got broad electric field and drops from frontal to occipital region. It is produced when patient is asked to repeat something. This is generated mainly because the polarity depends upon the direction of tongue movement. So tongue tip is electronegative and tongue base is electropositive. This results in the formation of glossokinetic artifact, and it is usually in delta to low theta frequency, and it is non-epileptiform. While SREDA is a frontal intermittent rhythmic delta activity, and it is in delta frequency, indicates global cerebral dysfunction, and it is considered as epileptiform. So this first EEG, we can see when patient is asked to tell la la la, we can see a monomorphic rhythmic activity in the frontopolar leads, which are stops saying the words. So this is easily reproducible, while SREDA is not easily reproducible. So it is seen bilaterally, it is expressed bilaterally, and it's mainly in the frontopolar leads, and abruptly stops when patient stops saying. So another DD for this is SREDA. In this we can see monomorphic rhythmic discharges of delta frequency, mainly expressed over the frontal region. with and we can see and this is epileptiform. So this is mainly expressed of the frontal region and it's monomorphic rhythmic discharges and it is not easily reproducible as glossokinetic artifact. And the last one is electroretinogram artifact, which is actually an artifact produced during photic stimulation. So it is time locked with photic stimulation and it has got low voltage. It is described as low voltage, repetitive, spiky discharge seen in the frontopolar plates and disappears by covering one eye. It's non-cerebral origin. It is produced by retinal neuronal cells. When eye is covered, this potential is not produced. So that itself indicates it's a non-cerebral origin. This differentiates it from the other artifact produced by the photic stimulation. It is usually obscured by normal EEG activity over the frontopolar region, but can be misinterpreted as cortical activity in patients with a devastating neurologic injury. So in this first EEG, we can see this is a bipolar montage with a sensitivity of 10 microvolt showing there is a discharges in which is time locked to the photic stimulation, which is mainly expressed over the frontopolar region and in next and it is bilaterally expressed. We can see in both right and left, these discharges are coming repeatedly, which is time locked with the photic stimulation. And in second EEG, we can clearly see when right eye is covered, it disappears. And it continues in the left side region, that is left frontopolar region. So when right eye is covered, it disappears. It clearly indicates that it is non-cerebral origin. It is produced by retinal neuronal cells. And when right eye is covered, the potential is not produced. One is 40 cell artifact. It continues because
this is a similar to the mathematics, but the one is different. One is anterior, the other is posterior.
So this is electroretinogram artifact. So we have covered benign named variants and other epileptiform variants. So in drowsy state, mainly we can see BSS, that is the most common benign variant, post, Wickets, 14 and 6 Hertz, fold, RMTD, SREDA. SREDA we can see both in drowsy and awake state. In awake state, we can see lambda waves, zeta waves, mu rhythm, WAM, and SREDA. So, careful interpretation of EEG patterns along with clinical history and demographic details is essential to differentiate benign variants from epileptiform discharges. And this non-specific transient can pose diagnostic challenges. It is important not to overcall EEG findings as abnormal and always interpret these findings in clinical context for the accurate diagnosis. Otherwise, it can cause misdiagnosis, over-evaluation, and over-treatment of the patient.
One of the
So identify this benign variant. This is VSS. This is low amplitude spiky waves with short duration expressed in wider field with no aftercoming slow waves, but sometimes it is associated with aftercoming slow wave, and it does not disrupt the background and can repeat, but not in burst. So it can repeat. So the closest DD is, this is a common average showing the same thing, spiky discharges which expressed over the wider field, which is biphasic in nature. And closest DD is EKG artifact. The main difference is it is time locked with the EKG, and it is mainly expressed over the left posterior head region in short neck individual. And it repeats, but it is time locked with the EKG artifact. So, sir, Wicket waves, we can see burst of archiform waves seen in the temporal region. Here also we can see the burst of archiform. It comes rhythmically with the phase reversal in F7. Same EEG in common average, showing archiform pattern, mainly expressed over the temporal region, and it repeats. And the DD for this is temporal spike. There is a spike and wave discharge. There is aftercoming slow wave, which disrupts the background, and there is a phase reversal. So this is clearly epileptiform. So one of the DD for this Wicket waves is temporal spike. It's the same thing in common average, showing maximum amplitude in F8. So this is 14 and 6 Hertz spikes. This is a prominent positive spike followed by a small round negative wave. So prominent one is positive spike, which is followed by a negative round waveform, which is expressed mainly over the posterior head region. And same patient can have 6 Hertz also, but still it is called as 14 and 6 Hertz. Same morphology, archiform, prominent, positive spike followed by negative wave. So this is phantom wave. We can see initial small spike followed by a prominent round negative wave. So the spike is usually small and it is missed. That is why it is called phantom wave. So WAM and fold is an old classification. In this is fold, but it is mainly expressed over the frontal region, also in the occipital region. So initial small spike is usually missed and it is very small. That is why it is called phantom. It is followed by a negative wave. In this, we can see the initial small spike followed by the wave. Here also, this small spike is usually missed. That is why it is called phantom wave. And it is WAM. It is mainly expressed over the frontal region. It's bilaterally expressed, and patient is in awake state. So this initial small spiky component is usually missed. This is phantom wave. And it has got abrupt onset and offset. And one of the DD for this is generalized spike and wave discharges seen in IgE. So here there is a prominent spike followed by the wave. So this this is frontally dominant, and there is a burst of generalized discharges with a prominent spike followed by a wave. So this differentiates it from the phantom wave. In phantom wave, this spike is very small and it is usually missed. But in generalized spike and wave discharges in EEG, there's a prominent spike. This is RMTD showing rhythmic monomorphic theta rhythm, which is abrupt in onset and it is expressed over the left temporal chain. And there is no evolution, abrupt onset and offset. There is no dynamicity. So there is no evolution. So that differentiates it from the ictal rhythm. Same thing in common average. And one of the DD for this is SREDA. This is sinusoidal with a frequency of 1 to 2 hertz frequency. That is in delta rhythm. SREDA is epileptiform. This is also expressed in the left temporal chain. Another one is temporal ictal rhythm, another DD for this RMTD. So it initially starts as polymorphic theta to delta frequency discharges, which is expressed bilaterally, mainly over the right temporal region. And it ends as slow delta rhythm. So there is a clear evolution in frequency. And it is not abrupt onset. So this is ictal rhythm. So this is SREDA. We can see there is abrupt onset monomorphic waveforms, which is theta, which is in delta frequency, mainly expressed over the posterior head region and predominantly expressed over the right side. And this continues, and when patient is alert, this abruptly stops. So there is an abrupt stop. So there is no evolution, there is no dynamicity. So this is again a non-epileptic. Other waveforms, you can see lambda waves. When patient is in awake state, in eyes open, when eyes are open, you can see repetitive discharges mainly in the expressed over the occipital region, sharps over the occipital region, which is attenuated by eye closure. On eye closure, we can see there is an appearance of alpha rhythm, and it is expressed bilaterally. Mu rhythm is central alphoid rhythm, which disappears on wiggling of his thumb and reappears when wiggling stops. And it again disappears on wiggling of his thumb. And it is seen in autistic spectrum disorder patients, and also it is overexpressed in breech rhythm. Normal physics. So these are post. You can see initial negative phase followed by positive waves, and this is run of post. Waves are coming repeatedly. Initial positive phase followed by a negative phase. The next one is triphasic waves. Initial small negative wave followed by a second component that is prominent positive wave of maximum amplitude followed by a negative slow deflection. So this comes periodically with the anteroposterior lag. Maximum over the frontal region and less prominent over the occipital region because it's projection from thalamus, differential projection from thalamus. And it's seen in metabolic encephalopathies, hepatic encephalopathies. Next one is zeta waves. We can see Z-shaped waveforms, which is mainly expressed over the frontal region. And we can see patient is in awake state. It is seen in focal structural lesion, which is acute or subacute. So these are theta waves named because of its shape. And mimickers are glossokinetic artifact which is produced by patient when saying la 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 or something else. It is easily reproducible and abruptly stops when patient stops saying. And it is mainly expressed over the frontopolar region. You can see monomorphic rhythmic activity in the frontopolar leads, and it is expressed bilaterally. And another DD for this SREDA, which is epileptiform, we can see monomorphic rhythmic discharge of delta frequency, mainly expressed over the frontal region, and it is epileptiform. Last one is ERG. You can see the repetitive discharges, which are time-locked with the vortex stimulation, mainly expressed over the frontopolar region associated with other artifacts. It is usually missed because of this frontopolar regions are usually associated with many artifacts. So this in this we can see it is bilaterally expressed. When right eye is covered, it disappears on right side. So it indicates its non-cerebral origin. So this is ERG artifact. So we are concluding today's session. Thank you. Thank you for listening.